ENT specialists, ENT nurses, primary care nurses, audiologists, and hearing aid dispensers. We had a client here who attended earlier today. He had wax in both ears. I actually did the procedure the opposite way around. I started with his right ear and then subsequently obviously his left ear, but here I've actually just switched it around. I'm showing the procedure for the left ear first, just because it was a lot quicker and simpler procedure, and also because the right side at the end, I'm going to show a still image of the patient's eardrum, which, as you can probably derive from the title of the video, is very heavily traumatized. And we're going to have a quick chat at the end to discuss possibly some of the causes. So nearer to the end of the right procedure, I will kind of identify potential causes for the trauma, because it's not what I thought it initially was. So the left ear canal, you see there's a bit of matted earwax. It's quite sticky, glutinous as well on the outside, but the core of the wax is quite hard and solid. Just trying to wriggle this out. It's just near the entrance, but it's quite impacted. It doesn't want to come out. So you can see the ear canal itself is a bit, I wouldn't say it's collapsed in the clinical sense. So you get patients with collapsed ear canals where the ear canals literally have fallen upon itself, the entrance, so you have to stretch the ear completely open, but it is quite a narrow slit, horizontally slit ear canals. Generally speaking, ear canals are more slit vertically. So if you imagine you've got a rugby ball or American football ready to be kicked, so the two pointed ends are north and south. This patient's ear canals, they're more horizontal, so the narrow parts of the oval are east and west. So I've just gone in with an ear hook, trying to get in behind into the center core of the wax. It is very hard, so as soon as I I'm trying to get the ear hook into the wax, because it's so solid in the core, the ear hook is actually just slipping away. It's not penetrating, so it's gliding off the hard core. So I'm just going to the posterior canal wall, just trying to get, almost trying to chisel into smaller pieces. But eventually I did get it out in one big mass using the ear hook. So again, just trying to, because when you're in the outer third, I can put a bit of pressure against the canal wall because it's made up of cartilage. If we were going further in with the ear hook in the inner 2/3, we wouldn't have been able to do that because the ear canal is very sensitive. It's skin on bone, a very thin layer of skin, 0.01 millimeters, whereas the outer third of the ear canal, the skin is a lot thicker, 1 millimeter in thickness, and it's made up of cartilage and some fatty tissue, so it has a bit of a buffer effect. So I think here, managed to get some purchase with the ear hook, and I'm just bringing this wax forwards, almost rolling it forwards. There we are. That's a big chunk. And still another piece. So again, I can just try to insert it through the gap between the anterior canal wall, so the front part of the ear canal. There's a bit of a gap there, as you can see, so that's what I'm targeting. There we are. And this wax is a bit deeper, so as soon as I'm in the gap, I have to rotate the ear hook away from the canal wall, not to make contact with it, and then bring it through. And it's almost all out now. Again, I'm just inserting it via the anterior canal wall. And there's another large piece that we managed to remove. Just some residual keratin, dead wax at the entrance, just using the Zollner suction probe to extract that, and that's the patient's left tympanic membrane, eardrum. That's how it should look like. You'll see now we're on the right side, the right eardrum looks completely different. So this wax, again, it's really occluding. It's right from the entrance all the way to the eardrum. Just starting off with Zollner suction probe. So the wax on this side is a bit softer. It wasn't as hard as the left side. So I'm just starting off using some suction probe. You'll see during the procedure I used an ear hook, but the ear hook and also a Jobson horn, but it was just slicing through the soft wax, it wasn't extracting it, and so eventually I used some olive oil drops to soften the earwax a bit more so I can get a suction grip and to lubricate the ear canal walls. But whilst you're watching the video, I'm just going to discuss in advance, before you see the eardrum, possible causes. So once we remove the wax, you'll see the eardrum, and on first appearance to me, the eardrum appeared as though it was about to rupture. There was glue, some middle ear effusion, infected discharge behind the eardrum that collected and it was causing the eardrum to bulge out, and that happens due to secondary, typically to eustachian tube dysfunction, or a nasopharynx infection, so an infection at the back of the nose where all the discharge travels up the eustachian tube. So the eustachian tube isn't blocked under that instance, but the infection originates from the back of the nose up the eustachian tube, which is a narrow tube that connects the middle ear, the cavity behind the eardrum, to the back of the nose. Or alternatively, if the eustachian tube gets blocked and it typically gets blocked at the back of the nose, it creates a vacuum behind the eardrum. There's no air there. So eventually all the cells in the middle ear, there's no more oxygen, and there's not enough air to replenish the oxygen that has been vacuumed out. So as there's less air pressure behind the eardrum, that causes the cells to secrete fluid, moisture, out of the cell. So it's almost like the cell fluid itself into the middle ear where it collects. So you can get fluid in two ways. I'll just recap that. Either there's an infection at the back of the nose, and that infection travels up the eustachian tube into the middle ear behind the eardrum, or when the eustachian tube is blocked, it creates a vacuum, all the air is kind of sucked out of all the cells in the middle ear, which then naturally causes fluid to ooze out of the cells into the middle ear, which then it collects, and we call that middle ear effusion. Eventually that fluid becomes infected and it turns into a very viscous fluid, hence the term glue ear. And just like a blocked drain pipe, eventually all that fluid has to go somewhere. So if you've got a blocked sink at home, eventually all that blocked fluid and all the debris that's been collecting in the drain pipe will explode into your sink. And in the case of the middle ear, eventually it penetrates out of the eardrum. So on first appearance, I thought you might have a bit of glue ear, but I did a test called tympanometry, which assesses the middle ear function, the impedance. And if you've got glue ear, the eardrum won't vibrate. There'll be no vibrations. The fluid behind the eardrum stops the eardrum from vibrating. Hence, people obviously can't hear with a glue ear generally very well. However, his eardrum was vibrating absolutely fine. There was no issues whatsoever. So you can see the eardrum now, it's in view, and right in the middle, where the hammer bone is in the centre, we call that region the umbo. So that's a region where the hammer bone attached. You can see it's very red. At first I was wondering whether that was a perforation. Either side of that, you've got a big swelling and bruising. At first I was wondering, is that earwax? But it's not. You can actually see that it's not earwax. It's actually a bulging of the eardrum, and it's on both sides, anteriorly, so to the front of the eardrum, and posteriorly. And in the middle, there's obviously a lot of inflammation. So I'm just want to check that this isn't wax, and there's a bit of debris on top of that. I'm just touching the surface of that, and I can you can't see it in the video, but I felt it wobble kind of, so there is a swelling there. Just there. It's heavily bruised. So it wasn't glue ear. You can get something called a glomus tumour, but it typically occurs and develops at the base of the middle ear. So you normally see that at the bottom. Again, with a glomus tumour, typically you won't get movement of the eardrum. So then I asked the patient, had he been poking in his ears? And he did say he's been using his finger quite a lot, actually. So that's probably the most plausible reason, I feel. He also mentioned, as a 14-year-old child, he had a firework that exploded. He wasn't sure which ear it was, but could have been the right ear, and it did leave him with temporary threshold shifts, so temporary hearing loss. But since then he's also developed intermittent tinnitus. So tinnitus is a ringing or buzzing noise that originates from within the ear or the head, so it's not an external stimuli. And it could have been that firework caused acoustic trauma, caused just permanent damage to the eardrum, and that's what his eardrum looks like. There's definitely not a hole there. He's definitely not got glue ear. It's not laryngitis, because that looks a bit different, and I've just taken another still image. But patient's symptoms are completely resolved. We're very happy indeed. Told him not to wait so long until next time. Just under 0.6 grams worth of wax, just under 600 milligrams. I hope you enjoyed that video, guys. I just thought I'll explain the findings of the patient's right eardrum and how traumatized it was, and the possible reasons as to why that is. If you're watching on YouTube, please do subscribe, select the bell icon so you'll get notified as and when I upload new videos. If you're watching on Facebook or Instagram, please do follow the page, like the page, and have a great weekend, guys. And